It's very common for all of us to occasionally have thoughts that involve killing ourselves. Driving over a bridge, we might have the thought to drive our car off the bridge into the water. Standing on a balcony, we might have the thought of jumping. These are very common, everyday human associations. Being on a train platform, it's common that the brain might tell us to jump in front of a train. Persons with OCD have these very naturally occurring thoughts, but they're accompanied with a profound distress signal, as if that this person is no longer safe, but this person might be not only having the thoughts, but therefore more likely to act on it. Persons with suicidal OCD become overwhelmingly desperate to ensure that they won't impulsively act out on these thoughts. They are more connected to the idea that if I think about killing myself, if I have that thought about killing myself, and my brain produces that thought, that might implicate their greater likelihood of actually acting on that thought. For most people who have thoughts of harming themselves, it's a coming and going thought that lasts maybe 3 seconds. Maybe you feel a little jolt of the heebie-jeebies, and 3 seconds later the event is over and you're on thinking about other topics. Common symptoms of persons with suicidal OCD involve a tremendous amount of preoccupation with trying to figure out how likely is it that they might act on the thoughts, how in danger are they, do they feel depressed? So there's a great deal of answer seeking involving just rumination within one's own mind. There might be a great deal of answer seeking in terms of going online and seeing if there's a differentiation between people who are suicidal versus people who are just anxious about suicide. It's a tragic reality that many patients with suicidal OCD are misdiagnosed by clinicians who don't understand that this is one of the variety of OCD's topics and might actually suggest hospitalization for the patient's safety, not recognizing that the patient is just anxious about the topic rather than actually having a specific intention about the topic. Common misconceptions about suicidal OCD is the idea that having the thought might implicate that the person is more likely to act on it. So not only might loved ones not recognize it just as a natural association, but they might become very, very concerned for the safety and welfare of a person with OCD who has this spike theme. It's comforting for me as a clinician to know that the suicide rate of persons with OCD is only slightly higher than persons in the general population. Persons with OCD can become very anxious about suicide, but most often don't act on it. And so persons with OCD are just driven to actually save themselves, and therefore it's sort of a contradiction to being suicidal, since the entire driving nature of the condition is the idea of safety seeking. The standard treatment for persons with suicidal OCD is exposure and response prevention, involving having the patient voluntarily conjure up associations about their potential for suicide, or conjure up circumstances, let's say standing on a train platform or standing on a balcony, and purposely and voluntarily bringing up the associations that their brain is very afraid of. In this way, it shows the brain the irrelevance of the brain's topic. Recovery for persons with suicidal OCD looks like a person being able to have these self-harm associations in a way that's experienced by any non-clinical person, any person in the general population, to naturally have the brain bring up the thought and not have it set off a tremendous alarm signal of distress.